I'd like to start by warmly welcoming everybody both in Haywards Heath and online with us today to this panel discussion, which essentially is around optimising models for patient care, service delivery, with a specific focus on stigma, mental health, integration and sustainability, drawing on insights from 3 diseases: lymphatic filariasis, podoconiosis and leprosy, with perspectives from 3 communities, organisations. So we have 4 esteemed speakers on our panel, starting with Dr. Maya Semrau from Brighton, Sussex Medical School, who is a fellow in implementation research and part of the Endpoint Consortium. Secondly, we have Hayley Mabelson from Liverpool School of Tropical Medicine, and she's the lead in Ascend for lymphatic filariasis patient care. Then to Sightsavers, we have Heather Burgess, who former lead with the UK Aid Match support to LF and Onco, and now the coordinator for project delivery for Ascend. And fourthly, we have Louise Hamill, who is in the NTD Technical Hub here at Sightsavers, and she leads on lymphatic filariasis and onchocerciasis. So there are 4 panelists, and we're going to start with a brief presentation from each panelist about their respective programs, and then we'll come on to 4 questions for which each panelist will have their responses, but we really want to encourage everybody in the audience and online to ask their questions and participate as much as possible. So we'll start straight away with the presentation from Maya.
Hello everyone, can you hear me at the back? Great. Yeah, so hi, so I'm Maya Semrau. I work at the Brighton and Sussex Medical School in the Global Health and Infection Department. And I'm just going to give a very brief introduction to the project that I've been working on for probably about a year and a half, a bit longer, the Endpoint project, which is a project on integrating a holistic care package, which includes both physical but also psychosocial and mental health care for people with podoconiosis, LF and leprosy in Ethiopia. First of all, though, we thought it would be useful just to give a brief overview of each of those 3 conditions, podo, LF and leprosy. So what all those 3 conditions can result in what's called lower limb lymphedema, so swelling of the lower leg and feet. They all have different causes, though. So podoconiosis is caused by long-term exposure to a particular type of red clay soil, which is found in specific geographical areas around the world, particularly in the tropics, at quite a high altitude, where there's heavy rainfall, where there's basically these ancient volcanic deposits that result in this red clay soil. It's very common in barefoot farmers who, on a daily basis, are exposed to this particular soil, but there is an underlying genetic susceptibility as well, so some people are more likely to get it than others. The main characteristic is what's called this mossy foot. So at the severe stages of the disease, as you can see on the pictures, it results in this kind of very swollen feet, which can progressively travel up the leg. And it can result in very painful acute episodes as well. Ethiopia is one of the countries that has the highest prevalence of what we know so far of podoconiosis. There's about 4% prevalence, and around 2/3 of all lymphedema cases in Ethiopia are due to podo. LF, on the other hand, is caused by a parasite that lives in the human lymph system. And the parasites then mate and basically release these worms into the bloodstream of the person. And then transmission between 2 people is through mosquito bites, so it's transmitted from the blood from one person to another, although repeated bites over several months or even years is necessary to get infected. Some people who carry the disease can actually be asymptomatic. Get symptoms. One of the symptoms can be the contrary to PODO, usually it happens, the way it travels is from further up the leg down towards the foot rather than the other way around with PODO. Other symptoms are swelling in other areas of the body, so hydrocele, for example, in men, swelling of the scrotum, or swelling in arms and breasts and other parts of the body as well. And then leprosy is caused by a slow-growing type of bacteria, which can result in very severe and disfiguring skin sores and ulcers, and also nerve damage in particular areas around the body, so arms or legs or other skin areas. It can result in a loss of sensation, which means that people who are infected might not realise that they have these ulcers and sores, which then exacerbates them and makes them worse. It can also result in muscle paralysis and blindness as well, and it can result in amputation of limbs or fingers because these ulcers and sores get very extreme. It is contagious, though only mildly, through very close and repeated contact with someone whose leprosy is untreated. And the incubation periods are quite long, so at least sort of around 3 to 5 years makes incubation difficult. So those are the three conditions that we are aiming to provide care for within the Endpoint project. So as I said, all three diseases can result in the swelling of the lower leg and feet, lower limb lymphedema. And the basic morbidity management and disability prevention treatment for this lower limb lymphedema is basically hygiene, so washing of the feet with soap and clean water, skin care, elevating the foot particularly at night, and exercises, and then shoes as well, so footwear. So for PODO, that is also to prevent getting the condition, so to prevent exposure to the irritant soil, but also to make sure that disability doesn't progress further for LF and leprosy as well. Counselling, patient counselling can also be included in basic MMDV packages, and there's also other, the more severe the stages, there might be other treatment as well, such as wound care, bandages, massage, surgery, and so on. So currently in Ethiopia, most of the MMDP care is provided by NGOs rather than being integrated into the routine health system. And that is what we're trying to address within the Endpoint programme. So the aim of Endpoint is to integrate and scale up the holistic package of community level care, which includes physical care, but also psychosocial and mental health care as well, into the routine health services for people with PODO, LF and leprosy in Ethiopia. In terms of where Endpoint is set, so we're try and point it out. So we're implementing in Awi Zone, which is there, which is in the Amara region of Ethiopia, in the northwest of the country. And we're conducting the study over 3 different phases. So we've just come to the end of the first phase now, we're moving into the second phase. So the first phase has been going on for the last year and a half, where we've been using different strategies to think about what kind of interventions we might want to include in the care package. So we've been doing key informal interviews and focus groups, we've been doing situation analysis, we've been doing theory of change workshops, we've been doing other workshops to ask people what they think should be within the care package and so on. And that's just come to an end now, and we're moving into the second phase, which is basically a feasibility pilot study within one single health facility in Awi Zone. And we're going to be testing some of the interventions within the draft care package and evaluating that as well through qualitatively but also quantitatively as well, through various different questionnaires and as well as key informant interviews and focus groups. Sorry. And then the third phase will be starting towards the end of this year, where we'll be scaling up that care package into 3 whole districts in Awi Zone and then evaluating the impact of that care package. And just to say, we're not just looking at, we're looking at patient level outcomes, but we're also looking at implementation outcomes as well, so things like feasibility and acceptability and things like that. So, in the, So just to very quickly maybe give you a flavour of the kind of interventions that we are thinking about including in the care package and that we are testing at the moment. So we kind of sort of divided them up according to healthcare organisation level, health facility level and community level. And we're trying to implement interventions at each of those three levels of the healthcare system. So, and that kind of includes a broad range of interventions that includes kind of basic or essential MMPP care, so limb care, but also psychosocial and mental health interventions as well, and that includes stigma reduction interventions as well. So at the health organisation level, we're going to be doing a training of trainers, for example, for people, for example, for decision makers, staff members of the Ministry of Health and so on, in limb care, mental health and so on. I don't think I'll go through each of them. You can have a look at that in more detail if you're interested, but just to maybe give you a flavour. So, so at the facility level, again, we'll be training health staff there to deliver treatment, mental health care as well as limb care. We'll also be doing some awareness raising activities to reduce stigma, clinical mentoring, supportive supervision and so on. And at the community level, we'll also be training community health workers to deliver mental health care and refer people who need more specialist care as well as MMDP care. And we'll also be training them to train other members of the community to facilitate community conversation groups. So that's one of the interventions at the community level, as well as active case finding and community health workers to refer to health facilities. And we'll also be doing self-help groups as well. So this is kind of a draft form because we're sort of moving into the pilot stage. So we'll see what happens during the pilot stage, and then we'll obviously probably go back and need to make some changes. This is just very quickly the training structure that we'll be using. So we're going to be doing a TOT, it's a training of trainers at the health organisation level. They will then be training zone and district level health office staff, who will then be training health facility centre staff and community health workers, and they'll be training members of the community. I'm going to say, apart from this, is the whole team that's involved in endpoints. So we've got quite a large core team, many of whom are based in Ethiopia, and then also a consortium as well, and we're funded by the NIHR as part of the Global Health Research Unit at BSMS.
Thank you, Maya. If we can pass the mic now to Hayley.
So I'm just going to give a brief overview of the work that was done by LSTM under the last DFID-funded LF elimination programme, so the work pre-Ascend. So we were funded by DFID from 2013 up to 2019 to work on the LF elimination programme, and this was to cover 12 countries across Asia and Africa, and included MDA as well as from 2015, they included morbidity management, disability prevention activities. So this included activities such as mapping for lymphedema and hydrocele, services for lymphedema management and hydrocele surgery, and also monitoring quality of services and access to care. So since 2015, just a brief overview of the different elements within each of these areas, we conducted patient searching activity across most of the countries, and this was done either using mHealth tools that we developed in-house. So Measure SMS was a text message reporting system that we used to train community health workers to text in cases of lymphedema and hydrocele as they identified them. We've integrated with other conditions in different contexts. So one example was in Ethiopia, we did a burden assessment of podoconiosis and lymphatic filariasis together, and integrated case finding in the MDA and into routine reporting. So trying to strengthen the system and continue the reporting throughout the lifetime of the programme and beyond the DFID support as well. We trained healthcare workers in lymphedema management, so they were trained to then train the patients and caregivers in self-care for lymphedema, and also delivered hydrocele surgeries. So we conducted training sessions for national for surgeons from within the countries, and also scaled up through both camps and integration into the health system. So the aim as well was to ensure access to services long term. So just to kind of give an overview of the scale of this, the lymphedema management training was all aligned with the WHO recommended package of care for lymphedema, and was cascaded down through the health system, right down to the community health worker level, who would then train the patients in self-management of the condition and also refer patients when they were having acute attacks. And in total, we trained over 47,000 community healthcare workers and 50,000 total health workers across the countries. And hydrocele surgery, it's cut off the bottom of the slide, but essentially we worked in multiple countries and delivered between 2015 and 2019 over 37,000 hydrocele surgeries. And this was done in different methods in different countries. So one example you can see at the bottom was Mozambique, where they integrated delivery into the health system, and we were able to conduct over 21,000 hydrocele surgeries in this way. And they also integrated indicators for hydrocele surgery into the HMIS system, so we had reporting in the national systems as well, so ensuring alignment with that and not vertical reporting. In other countries, such as like Burkina and Bangladesh, they were done in camp formats, and this was just enabled us to reduce the backlog of disease while training surgeons to be able to continue to provide surgeries longer term as well. And then in addition to this, we did a number of monitoring and evaluation activities across the countries. So, and this was really to help us provide additional evidence of the impact of this work, both to donors and within the countries. And this included health facility assessments to assess the quality of services within the health facilities for lymphedema and hydrocele surgery, conducting access to care surveys, so ensuring that patients were then actually accessing the services that had been put in place and being able to improve the access in this way. Pre and post intervention studies, so monitoring the impact in looking at quality of life, particularly for the hydrocele surgery, so assessing the change in quality of life before and after the surgery for the men and also their families as well. And caregiver studies, so looking at the impact of these conditions on the wider family, so not just the person affected, but their caregivers, their children, so that we could show to DFID and to the national programmes the wider impacts of the work. So if a man receives hydrocele surgery, the whole family benefits, and we were able to show this through the caregiver surveys as well. So this is just a snapshot of some of the work that was done under the last DFID programme that will be fed into Ascend and will build on during the next programme.
Thank you, Hayley. We'll now pass the mic to Heather and Louise from Sightsavers.
Hi, so yeah, this is going to be a brief introduction to what Sightsavers has done so far with what we kind of wrap up as patient care services. And this is also Marie, who lives in the Katanga region of DRC, who has lymphedema in her right leg, who we'll meet later. So when we talk about patient care in Sightsavers, we generally are talking about two diseases that we work with. So we have trachoma, which obviously we have vast experiences in the surgery and epilation aspects. And then we also talk about lymphatic filariasis, or LF, where in the past few years we've started working on hydrocele surgery and lymphedema, as these guys have been talking about. And The important thing that we want to do is take all of the learning that we already have from existing programs and feed them into our work in LF. And it's not just NTD work in trachoma, also we can learn a lot from the inclusive eye health projects. So it doesn't just have to be an NTD thing. When we're looking at holistic interventions, all other aspects of Sightsavers, the work is useful. So, we've kind of spoken a little bit about holistic interventions, and that's because people with an LF impairment, such as hydrocellular lymphedema, they're often subject to stigmatisation and sometimes exclusion from their communities because the cause of their impairment is often misunderstood and can be blamed in some cases on supernatural causes such as witchcraft. So that can have a negative effect on kind of mental health, and there's growing evidence base, which kind of these guys have been involved with, surrounding the links between NTDs such as LF and their comorbidity with conditions such as anxiety and depression. And we'll send out afterwards links to a lot of studies, but this one's just a little example of a paper that Louise here led on, which kind of synthesizes some of the evidence linking NTDs and disabilities and highlights some of the mental and social effects of NTDs as well. And as Hayley was mentioning, the stigma and kind of the stress of dealing with these conditions doesn't just affect the person with the impairment, but also the stretches to family members or carers of that person. So that's why when we talk about it, we want LF patient care services to be holistic and kind of person-centered, and they shouldn't just reduce the physical pain caused by the impairment, but we're looking to try and address the other negative effects that it might have on a person's life. So our specific experience so far has been through kind of two projects. So the first one would be the UK Aid Match Onco LF project, which just finished up after 3 years in March 2019, where we were working in areas of DRC, Guinea-Bissau, Nigeria and Uganda. So the LF patient care services that we did in that project were generally integrated with the mass drug administration. So that means that our CDDs that we were training anyway to deliver drugs from house to house, as they were doing that, they had pictures of what lymphedema and hydrocele looked like, and they would ask members in the house if they had any of these conditions. And once we'd done that, a trained health worker would then go in and verify the cases. The health worker would then either provide the person with training on how to manage the lymphedema, which these guys have kind of touched on the methods, or refer them to a kind of tertiary health facility where they could have hydrocele surgery. So we found kind of anecdotally from across the projects, a lot of people online will, this is there, if anyone from Nigeria or Uganda, Guinea-Bissau or DRC, I'm kind of speaking for them as such, but service users often went on to become advocates for the program. They encouraged other people to prevent with these conditions, but they also, we found, encouraged people to take part in the MDA because they understood the reasons of why they had the lymphedema, and they wanted to prevent other people, especially younger generations, from getting the same thing. So it was also the awareness raising about how these conditions come to be. We also found that more people came forward for treatment in the second year of the project than the first. And we do need to look into more detail as to why that happens. So we have some thoughts, but none of these kind of proven. But we do think that a reduction in stigma could be one of the reasons. So once people realise that, you know, these things are caused by mosquitoes, in LF's case, they aren't as embarrassed or ashamed even to come forward for treatment. They don't mind admitting that they have lymphedema or hydrocele because they understand that it's just caused by an NTD. And the other thing is that we found if people were living with it, they just assumed nothing could be done about it because it's not necessarily trained in their local systems. So knowing just that they can kind of have improvements in the quality of their life meant that they're more likely to come forward with something that they might be embarrassed about. Sorry, and I meant to say, tagging on, the Sightsavers office in Guinea helped implement Liverpool's programme that Hayley was talking about in Guinea. So, as Hayley mentioned, we're taking all of this learning from the organisations through into Ascend West, where lymphedema and hydrocell management is a key theme, so it's happening in all 13 countries. It's probably the only thing I think that's happening across all countries, so it's a really big thing for us going forward. And then I just wanted to finish on this picture of Marie again, who we saw in the first slide, and this is actually her getting a moto taxi on the way home from her local health centre, and she's there with her husband, and they've received training on how to manage her lymphedema. So it's the caregiver who receives training as well as the person affected, and the basin that they're carrying is kind of one of the tools they're given to maintain the treatment at home. So they're shown how to wash the wound and then given some just simple things to help maintain a clean environment for that leg.
So thank you to all the panellists for those rich presentations. We're now going to move on to a short session of 4 questions, which I'm going to pose firstly to the panellists, and then afterwards, if everybody in Haywards Heath and online, please do share questions. Anybody online, if you can type your questions, and Becky will voice them on your behalf. So the first question is, could you elaborate a little on how stigma actually affects people with NPDs, and specifically how it impacts access and uptake of services? And the second part of the same question is, what de-stigmatisation practices are and should be put into place? If we start with Molly.
Okay, thank you. Well, yeah, just to follow on what Heather's already said, I mean, there is a lot of evidence available now to show that people with lymphedema are heavily stigmatised. And that's stigmatisation by the community, so people might, for example, be excluded from community life, they might have difficulties finding a marriage partner, children might not be able to access school, and so on. But I think it's also important to point out that it's not just community members who might be stigmatising people with lymphedema and their families, but also health providers themselves as well. And I think that's a really important point for access to services, the fact that when people seek out services, if healthcare workers aren't sufficiently trained or are misinformed about the conditions, that they themselves might actually display stigma and discrimination towards people. So I think that's a really important point for access. In addition, there might also be self-stigma by the person, so the person might internalise the kind of stigma and discrimination they're experiencing, which can result in kind of low self-esteem and also avoidance of interactions with members in the community, but also in terms of avoiding accessing services as well. And that stigma, again, can then lead to what Heather's already said, I think, higher levels of mental distress and disorder, which can lead to kind of a double stigma, because often people who have mental health problems are also stigmatized. So they then face stigma not just for the physical symptoms of lymphedema, but also for the mental health problems that they might be experiencing as well. And there is some research, there's some qualitative research definitely on barriers to access to care for people with lymphedema and also adhering to treatment as well. And I think you'll get a list later of some references. But so I think, again, that can then lead to a sort of negative cycle as well. So when people are not accessing services, their functioning might decrease, their disability might increase, and that, again, might lead to higher levels of stigma. And there's a kind of negative cycle that can happen. Should I carry on with the second part of the question? Yeah. So in terms of just moving towards kind of stigma reduction interventions and what works, so I think what's been found is that using interventions that have multiple components to them rather than just a single component are what works best. So, for example, thinking about what are the different population groups that need addressing, for example, members of the community, the patients themselves who might be experiencing self-stigma, health workers who might also be showing stigma discrimination, and trying to address that, but also possibly addressing the different causes of stigma. So, for example, within PODO, misinformation about what causes the disease can lead to stigma. So people might, for example, think that's contagious, or which is not the case with PODO. So actually providing educational interventions to address that source of stigma might help. And that can be amongst health workers as well as members of the community. And I think I just wanted to mention as well, I think within the stigma field, there's a move towards seeing stigma not just siloed within conditions, but kind of looking at it in a more cross-condition, taking more sort of cross-condition approaches, and realizing that there are lessons to be learned from different other conditions, but also from completely different fields as well. So there's a paper that came out by Wim van Brakel earlier this year, which was a thing called Out of the Silos or something like that, which basically was just looking at the kind of cross-cutting components and looking at different conditions, not just NTDs, but also, for example, looking at stigma within the mental health field as well, and looking at what the cross-cutting components are there. So I think when you think about stigma, often you can take, not just address stigma for one particular aspect or just one particular component, but also, as I said, perhaps address the mental health stigma that people experience, as well as the stigma they might be experiencing for their physical problems. Yeah, so I think that's probably what I'll say for now, yeah.
Thank you, Maya. So I think some really valuable points there regarding, as you were saying, stigma among healthcare professionals is a key issue, and also this issue of it being siloed, and actually stigma is a cross-cutting theme. I'll hand the mic now to Lily.
Thank you. So yeah, I think Maya's done a really big overview of like the ways that stigma might impact people, but I think something that we found is like the way that it impacts on people's livelihoods as well. So then it further increases this cycle of poverty that we know exists within NTDs. And I think that we've done a lot of work, obviously training healthcare workers, which will hopefully mitigate some of the impact of the stigma that health workers then have towards patients, but also with community members, so both through the MDA but also messaging just specifically on lymphedema and hydrocele or the causes, so providing like information to the communities so that they have a better understanding of the causes of the disease, which then might reduce that stigma. As well, like in terms of accessing services, we've in some cases worked on integrated programs, so looking at integrating patients with lymphedema into leprosy self-help groups. So there is a lot established within the leprosy groups around community services, self-help groups and peer support, and there's a lot that we can learn in other NTDs from this. So one example is in Nepal, we did work with the Nepal Leprosy Trust to integrate lymphedema patients into the groups that were already existing at the community level, but before that we did some work around like would that be acceptable to the participants of the groups, and so looked at the stigma of those with leprosy towards LF and people with LF towards leprosy, and whether people would be willing to integrate. And most people were willing, but there was quite high levels of stigma, and we found that after 6 months, a year, the levels had reduced. So I think it's not only the community, it's also people with different conditions, and I think it needs to be considered. I know we'll talk about integration later, but in that sense as well. And also, like, touched in presentation around caregivers, and I think that we know that then the stigma affects not only those that are with the condition, but their families and the wider circle as well. So we've done a lot of work with the national programs to include caregivers in training, so that they're also aware of the causes of the condition, and including community members in group training sessions, so that it's participatory in that way as well. And hopefully that increases the uptake of the services, but also maintains the service people's adherence to the services if they have that support from the families as well.
Thank you, Hayley, specifically for mentioning about the point of the training, extending the remit of the training to those caregivers and other community members. If we pass the mic now to Sightsavers, to Louise and Heather.
Sure, I'll just say a little bit about this. I think Maya and Hayley have already given us lots of information, and one thing that we could conclude from that is there's a lot of evidence sort of in the literature, and a lot of studies have been done to show that NTDs and stigma associated to them have a really profound impact on people's lives. So yeah, people sort of internalize their stigma, they suffer shame and sort of low self-esteem, they can withdraw from activities or, you know, be excluded themselves. And I think the stigma around sort of healthcare providers is really important. It's something that we maybe need to look at a bit more, because even in the work that we did in Uganda, some patients, like the awareness among healthcare providers at the start of the activities was very low. So patients who took part in like the knowledges, attitudes and practice surveys reported that, you know, they were getting knowledge in healthcare providers was so low that they suffered a lot of misdiagnosis. They were journeying back and forth to the health centre a lot, which is like painful, demoralising, and it just goes to show that at a very basic level, the healthcare workers didn't have the knowledge they needed, and that was something that we were able to work on going forward. Yeah, I think in terms of destigmatisation, just as well as to echo the point that Heather mentioned during our presentation, that's not just necessarily an NTD thing and like limited into that little silo, and we shouldn't think of it that way. There's a lot of work happening in other areas, sort of like broader health systems in Sightsavers and beyond, to look at how to do destigmatisation, easy for me to say, and you know, try and make sure that inclusive the health systems are sort of what we're working towards. So I think just a point that there's lots of evidence, like from within the sphere of NTDs, but also more broadly, that we can draw on and look for when we're trying to include best practice in Ascend and other programs that we're involved in.
Thank you. Before we move to the next question, we'll just pause for a couple of questions. We're time constrained, so I think it'll be just one question from the floor here in Haywards Heath, and then a question from online. Are there any questions from the audience? And the question is, please, have there been evaluation of stigma reduction interventions, and how it has impacted or reduced the quality of life of patients? So I'll pass that to perhaps Maya first.
I think within particularly the PODO and LF and leprosy field, let's say there's emerging evidence on this. So there are some studies, I think, which are using stigma reduction interventions. I'm not sure whether they've looked at in terms of directly on the quality of life. In a way, I could say watch this space, because we are definitely looking at that within endpoint. And quality of life will be one of our outcomes. I'm trying to think off the top of my head whether I can think of a study that particularly looked at quality of life. But yeah, certainly in terms of the evaluation of interventions, I think there is emerging evidence for that. And again, looking wider beyond the NTD field, for example, looking at the mental health field, there are a range of different interventions that have been looked at and looking at stigma reduction interventions specifically.
Okay, we're going to move on. Thank you, Maya, for introducing actually the next question, which is around, you said about mental health. So the next question is, what is the need for psychosocial support, and how is it best provided?
Yeah, so as we've already, I think, mentioned throughout this session, so again, there's emerging evidence, particularly for PODO, LF, and there's probably a bit more evidence for leprosy around the fact that there are very high levels of mental distress and also mental disorder amongst people with these conditions. So, for example, there's been a few studies now on looking at depression or mental distress amongst people with PODO. There's also a study in Nigeria that looked at depression amongst people with LF. And basically all those studies have found really that, you know, rates of mental disorder and distress tend to be higher amongst people who have these conditions compared to, for example, their neighbours who don't have these conditions. And there was also a study showing that the burden associated with the mental health implications of these conditions can actually be much higher than the burden associated with the physical health problems. So one study that looked at LF found that the burden that was associated with the mental health implications, the burden associated with mental health implications was double that of the burden associated with the physical symptoms. So the mental health problems that can go along with these conditions, or that these conditions can lead to, in terms of burden, can be massive. So I think there's definitely, and that's kind of what we're trying to address with an endpoint, is basically trying to integrate holistic care packages, so not just looking at the physical symptoms, but also to address the mental health symptoms as well. And so I think that's why it's so important to integrate mental health aspects within interventions, as well as physical care services as well, so that you fully address the burden associated with these conditions.
Thank you. And I guess the whole issue of the mental health burden isn't actually captured in our disability weighting for the diseases, and is a shortcoming. Let me hand over to Hayley.
Yeah, so I think for us, like at the programmatic level, psychosocial support in the health worker training is something that hasn't been as strong as other elements, and I think it's not as well defined within like the minimum package of care for lymphedema management. It's something that we include as it's flagged to the health workers as the need for psychosocial support to the patients, but something that definitely needs strengthening in the future. And I think there's a place for like the self-help groups and peer support groups, so that there's that peer support as well. And it's something, again, very well established within leprosy organisations, and probably a lot we can learn for the other NTDs as well.
Thank you. We'll hand over directly to Sightsavers.
Yeah, thanks. So just to sort of, again, echo what Maya and Hayley have said, like it is an area where I definitely think that it needs to be strengthened within the NTDs. There is some examples of, I think, peer-to-peer support groups in Haiti for LF, where they were sort of designed not only to help people learn how to manage the physical symptoms, but there was also a very strong and deliberate component of emotional support. So that, I think, is a really nice example within NTD specifically that we could hopefully learn on, as well as some of the other stuff that you guys mentioned. But yeah, I also think about how to sort of strengthen the community-based stuff, but also referral symptoms, like kind of almost acknowledge sometimes if we're going to go too far outside it, like spheres of expertise, that we want other people to be involved, so we're not like getting overstretched and stuff like that.
Is there anything else?
Yeah, I need to echo Hayley's point that the WHO, the kind of minimum package of care that they suggest for lymphedema is entirely physical, and until there's something kind of written down and globally agreed on that the psychosocial support is required, it's really hard to get funding for, and it's really hard to incentivize ministries of health, who have a lot of other pressing issues, to invest in, because they're already going to tick the boxes for evaluation without it. So, you know, they might not have much of a mental health system set up already. So yeah, it's an advocacy piece as well to make it more formalised.
Before we move on to the next question, are there any questions from the floor around psychosocial support or from online?
Or comments, not just
Comments,
questions,
yeah.
if anyone's just got their own experience.
Contributions, what I should be saying, any learnings from the other teams that are relevant to the discussion?
I would just like to comment on referring, and that's probably like one of the major issues in mental health within a lot of settings where we work, is there is actually no one to refer to. And that's like maybe something that we need to sort of consider in our programming when we think about potential interventions. Just a comment.
I don't know if that was picked up by the mic, but just a comment saying that, is there anyone to refer to in a lot of these contexts for mental health?
Just on that point, I mean, there's a cynical part of me that says, yeah, anyone who does a survey looking at depression in someone who's got a massively swollen foot, you know, we really shouldn't be surprised that they've got depression. So there's sort of no shit show moments. But it's really interesting to hear that actually sort of the burden of disease from that is double the impact of actually the physical condition. And I'm wondering if that is, I mean, obviously there's nothing intrinsically depressing about having a swollen foot, but what people think about you can be really depressing. And is it stigma and that self-stigmatisation that really drives that burden of disease? So there's so much the way to address that, come back to the earlier point about stigma.
Yeah, I think it's very much linked. So I think stigma and mental health is very much linked in that exactly the stigma can lead to mental health problems. But there might also be more coming into that, which is, for example, lost economic productivity, which might lead to job loss, or poverty, which again can drive mental health problems. So I think it's like more complex than just saying it's just the stigma that contributes. I think there's probably other factors as well, but I think that is probably one large element of it.
And is there one knock-on element in terms of there's a loss of livelihood, but does it affect how someone gains support from their community? Obviously, in sort of vulnerable communities, they're very resilient because people can draw on the support of their neighbours or their extended families. But do these conditions impact that sort of safety net that people can draw on?
I mean, there's definitely an example, actually, it's from your programme in Tanzania, but Charles Mackenzie tells it a lot, of a local butcher who had lymphedema and no one would buy meat off him because they believed it would be infected as well. So, yeah, again, it is the stigma, but that meant a loss of earnings from him, but also the community weren't willing to support because they just misunderstood what was happening.
Yeah, so actually in that situation, they retrained him as a carpenter as well, so that it was like a whole lot. I mean, this is going back like 15, 20 years, so a different time, but like it just shows that we also do probably need to think wider than just counselling, or there's a lot more to it. And I think the stigma again probably impacts on then people being able to have support from other parts of the community, because like to draw on that support, you're right, I think it's all linked in the cycle of
So, due to time constraints, we're going to move swiftly on to the next question, which concerns comorbidity and integration of disease management. What are the benefits, opportunities and challenges of integration?
So I think there are varying opportunities in different contexts, and it will vary greatly depending on endemicity of different conditions, how the health systems or the ministries of health are structured. So in lots of cases, the leprosy departments are separate from the rest of the NTDs. So opportunities that might seem very clear are a bit more politically complicated. So that will impact as well. But there's obviously clear evidence that integration is probably more cost effective, but also integration into the health system as well, and how that can improve the sustainability of the programs and ensure access to the services longer term than the funding might allow for. But then there is challenges within the funding. So again, it might seem clear in some situations to integrate LF with Buruli ulcer or another condition, but the funding restrictions mean that we aren't actually able to do that without mirrored funding from another department or another group. So that it's quite a complex situation. So I think there are different examples that we've worked on. Ethiopia's a really good example where we've integrated LF and podoconiosis within the Ministry of Health and providing the services in an integrated way. And that was for burden assessments, but also for service delivery as well. I mentioned earlier where we integrated LF and leprosy in Nepal, and that was within the self-help groups, but we've also integrated leprosy and LF patient finding in different settings as well. And in Malawi, they now have included MMDP training in the HSA, like the Community Health Worker National Training Programme. So that means that it's more sustainable as well. So there's a few examples from our work that we've tried to use different opportunities to increase the effectiveness really of the programme.
Hayley, you highlighted some of the challenges with the funding. Mm-hmm. Could perhaps you speak to a little bit to the issue of hydrocele hernia?
Yeah, so it's something that is kind of two issues really, I think. Like with the hydrocele and hernia, a lot of the time when patients are identified as having hydrocele, it's misdiagnosed and it's actually a hernia. And also there's cases where men have comorbidity of both conditions, and in terms of implementing hydrocele surgeries, we have that challenge then of what do we support, what are we able to support. So in our last programme, as part of the screening for and pre-surgery assessments for the surgery, they would confirm whether somebody had hydrocele or hernia or both conditions, but we weren't actually able to support hernia surgeries, and that would have to then be referred within the health system and managed elsewhere. So it's a challenge as well. It brings in that ethical questions of we're identifying people, we're inviting them to the hospital for surgery, but then we can't actually provide that service. So yeah.
Heather and Louise, are there any additional points that you raised?
I guess it was only the integration, as we said. At the moment, Sightsavers is only integrated within its other kind of NTD activities. So yeah, it's kind of reaching out to what other services could we integrate with kind of internally and with other organisations. And there are kind of cross-cutting NTD forum looking at this work alongside the NNN, which is kind of a global organisation, but it's reaching out, and it would be good to hear from kind of other colleagues. We've got an internal patient care working group about other aspects where we could integrate and not just think of it as an NTD, because we discussed it's a larger, more cross-cutting issue.
Maybe just to quickly just touch on some of the challenges that we've experienced so far with the endpoint. I think a lot of the other points were already covered. I mean, in some way, I guess, thinking from an endpoint standpoint, in a way, sort of watch this space, because we're just going into phase 2, the piloting, and this is kind of exactly the kind of question that we're looking at within the project. So in a sort of year and a half, hopefully we'll have very sort of detailed answers to those kind of questions in Ethiopia anyway. But in terms of what we saw, some of the challenges we've come across so far just in the kind of developmental stages and moving into the pilot phase within endpoint is firstly this point around integration of care with leprosy. So integration of care between PODO and LF seems, in Ethiopia at least, seems to be a lot more straightforward than for leprosy, and partly that is because in Ethiopia leprosy is handled together with TB, and PODO and LF are part of the entity department in the Ministry of Health. So there's kind of different groups that you need to address and work with, and that's kind of more tricky when it's not the same people that you're talking to. And they might not be as convinced to integrate leprosy with PODO and LF. Another question that we sort of came across was, whether we should just focus on the lymphedema or whether we should also focus on other symptoms as well, like hydrocele and other symptoms of leprosy, for example. Because we're obviously trying to take a holistic approach, but then I think that's sort of a question that's still standing for us. But I think we have to, within the programme, just focus on the lymphedema, but then that's obviously that's kind of question I think to still bear in mind with programmes. And then another challenge that we've come across, which is relevant for M&E, is the differences in staging systems between the different conditions. So they all have different staging systems that are commonly used. So, in order to evaluate the programme, which of those do you use? And I think you've mentioned you use some mild, moderate, severe or something like that.
Because
just cross-cutting across the three.
Yeah, so like LF lymphedema has a 7-stage staging process where PODO's 5.
Yeah,
so when we did the integrated burden assessment, community health workers were trained to identify lymphedema as just mild, moderate or severe, which meant that we didn't have to distinguish, because we were actually just reporting lymphedema or hydrocele, and we weren't necessarily concerned with the cause of the lymphedema. So it just enabled us to simplify rather than pick one staging system over another. So it's thinking like practically as well about things.
Thank you. Before we move on to the last question, are there any contributions from the floor?
Yeah.
We'll move straight on to the last question.
Should we just hold it for the next? I think people might have to go. They'll have meetings and stuff.
I mean,
we can continue.
no, if people need to leave, then absolutely. I think let's continue with the last question. And please, if you need to. So the last question was, how do we improve sustainability of service delivery? Let me hand that. Ryan?
Okay, maybe just very quickly. I think something that's come up a lot is I think the one important thing is integrating into routine health services, particularly primary health services. The other thing I think is involving key stakeholders and a wide range of key stakeholders right from the start of the programme and right throughout the duration of the programme to make sure that they're committed to the programme in the long term but also have ownership of the programme as well. I just wanted to maybe point towards the sustainability working group by the NNN who've offered or characterise sustainability and ownership by 3 different components. So they characterise it by accountability, so it should be outcome and task oriented. Domestic commitment, which basically means political will within the country, and also that services should be driven by community demand for those services. And then resource mobilisation, so that people within the country should be looking at the inputs and resources that are required those services, and that those services shouldn't just rely on external sources, so there should be some kind of internal funding available as well. But yeah, maybe I'll hand over.
Yeah, I think the key things that I would say is often sustainability it requires strong ownership from the national programme, and so it's working with them to understand what their interpretation of sustainability is, and that's where the sustainability working group has done a lot of work to establish that. And the clear way forwards in terms of morbidity management is integration within the health system. So trying to establish with the national programmes how we can best do that to ensure that patients have continued access to services beyond the funding that is available. I think that's probably the key thing, that and the reporting, integrating the reporting as well.
And from a Sightsavers point of view, we think this is kind of a perfect place to learn from trachoma, because as you've all probably heard through many channels, that's getting close to elimination, if you haven't heard. And they have a very set kind of transition planning. So it's kind of a clear cut-off in trachoma that if a prevalence is below a certain rate and your backlog's cut down to this much, that's the point at which the National Health Service will take over. And having that agreement kind of from the start, almost planning your exit from the beginning, means that no one's left hanging. It's not like, oh, we thought we were going to exit at that point, and the Ministries of Health saying, well, we haven't planned for that because we weren't expecting you to exit. So it's being really kind of clear, and maybe using the trachoma transition planning as a learning of kind of what went well, what didn't go well, and putting that in place for LF, because we're also getting close to elimination of that in a number of countries.
So thank you all, and thank you, Heather, specifically for raising awareness to the trachoma transition planning, which really does have a lot of valuable lessons. As we've passed 1 o'clock, unfortunately, we're going to have to close here. But if anybody does have any questions, please do email them, and we'll share them with the panellists and get back to you. In Sightsavers, it's probably worth just flagging that there is the patient care working group, which Heather alluded to, which is co-chaired by Bex Hill and Louise. So if you'd like to be more engaged, then this is the patient care working group. So thank you, and thank you also for participation online.
Great.